Jaipur Medical College. To take the case, we have senior intensivist Dr. Suresh Ramasubban from Apollo Hospitals, Kolkata. And another examiner is Dr. Anand Joshi, intensivist from Sydney. So Dr. Mohit and Himanshu, you can present the case. Over to you, sir.
Good evening, everyone.
Go ahead, guys.
Good evening, sir. I'll be starting with the case presentation. So there was a 29-year-old male. He suffered from an electrical burn on 27th of November. It was a high voltage 25,000 volt line, followed by a fall from about 15 to 20 feet in height. Location was Chittor. He was taken to a local hospital in Udaipur, and from there he was shifted to our own hospital, Mahatma Gandhi, on 30th of November. So the patient had complained of pain over both the shoulders and elbows, sir. So patient coming to the presenting illness, so he was all right before when he suffered electrical burns while working on a railway line on 27th of November. That was followed by a fall for about 15 to 20 feet of height. Immediate condition of the patient is not known. Then he was taken to a local hospital in Udaipur, and from there he was shifted to the Mahatma Gandhi Hospital on 30th November. That is after 3 days. He don't have any coming to past.
Can I stop you there?
Yes, sir.
Can I stop you there? Yeah. Right. Go back to the first slide.
Yes, sir.
And so this is basically not only what I can see is that this is not. We need the same mechanism, the injury mechanism, fall in height, what all. Where did was there loose wire that he held onto it? Where did it hit him? Was it what was the exact mechanism of injury? Was he trying to repair a line? What exactly happened is something which we need to know.
So he was working in the working on a line. He was repairing the line with the transformers and thing. Exact mechanism is not known, sir, because
did he touch a live wire and on his hand, or did the live wire come and hit him on his body or something?
The exact mechanism and the mechanics are not known because this patient is already discharged from a hospital, sir. So we couldn't, we ourselves couldn't take the history, sir.
Okay. All right.
You could have called the hospital. Did you call up the hospital?
No, sir. No, sir.
Okay. Did you speak to the family members or anybody who shifted you there?
Yes, sir. We later on tried speaking to the relatives and the family members, but unfortunately the patient's condition was not. The patient was not doing that great. So more history and in fact there were some relevant investigations which we wanted to have, which were done outside outside from our hospital. We wanted those investigations also, but we couldn't procure those stuff, sir.
So the reason Ram sir is asking you is why do you think these questions are relevant, which he asked?
Because sir, whenever in such cases, sir, there can be a direct volt injury, direct electrical injury is there if a person comes into direct contact. There is a reflective injury also, like in such cases electricity is conducted to some object and then it is transferred to the patient's body. And then there is indirectly the electrical injury can cause a burn injury also, a flame injury also. So that's why these history from the patient is important, sir.
What else?
So basically, you're trying to say whether it's a direct strike or a contact strike. That means if it is a contact strike, means in the sense you touch something which is already electric, or you touch the electric wire directly, and that makes a little bit of difference. Okay.
Sir, it is less likely a direct strike because I am saying this because there are no evidence of anterior exit wounds, sir.
Okay. This doesn't look like a direct strike to you.
No, sir. No, sir.
So it looks more like it's a contact with a live wire that he has come in, and there is the whole, maybe some part of his body. It's not his hand. It's not something. It's just that he probably touched the whole thing, whether it is his shoulder, whether it is his hand. We are not very clear from your history. Okay, got it.
Yes, sir.
All right, but
Yes,
as you rightly said, if there is no particular, if he touches with the hand, you have a significant thermal injury on his hand or where you hold the wire, and that sometimes is missing.
yes, sir. Yes, sir. So his palms was spared, sir.
So assuming you were the first responder,
Yes, sir.
when this patient is brought, what are the other relevant? Have you finished your history?
Yes, sir.
No.
The little bit of part is left, sir. But yeah, it is almost over, sir.
So assuming what is the history you would like to know with this first presentation? So he will be presenting as a what? A shocked, unconscious person or something like that, right?
Pardon, sir?
So this person, if assuming that you were the first responder, that is,
Yes.
this patient brought to you straight away in your hospital.
Yes, sir.
Okay. What are the relevant history you would like to know and why? This person would be presenting something like some loss of consciousness or something like that. So there will be a difference. Either he is an unconscious or he will be walking in, right?
Yes,
Yes,
sir.
sir.
Yes, sir.
So,
So
History of loss of consciousness, history of any ENT bleeds, history of seizures.
you need to tell
Because
me
it's
everything when you tell that. You need to tell me why you are asking that. Why do you want to know the loss of consciousness?
so because there is history of this. There is presenting in this, there is history of fall from height after burn. After
Okay.
in contact with electricity, there is history of
Yes.
fall from 50 feet. sir.
This is a burn, and you are asking for an associated injuries, right?
Yes, sir.
You need to rule out associated injuries.
Yes, sir.
What else? He has come with unconscious low GC.
So, sir, we'll start. If the patient is unconscious, then taking the history will be a challenge, sir. So we'll start away. We'll start with the examination, sir.
No, you need to know the history. There are certain important. Okay. To put the question in another way, what are the causes of low GCS? A person coming with a low GCS, what are your differentials in presentation with the history of say burns in general or electric bicycle? Tell me a couple of
Sir,
causes.
yes, sir. There can be inhalational injury also. Carbon monoxide poisoning can be there, sir, which can lead to low GCS. Since there can be because of the fall, there can be trauma to the head also. Traumatic brain injury can be there, sir. Until unless it is ruled out, then sir, there can be because it is a high volt electric injury, sir. There can be it can lead to cardiac disruptions, sir. So that thing also has to be that can also be there. Patient presenting with atrial fibrillations, bradycardia.
What other disturbances could you expect?
Pardon, sir.
One is
cardiac-
carbon monoxide. Anything else?
There are very few things that you need to know. Hypoxia, hypercarbia, carbon monoxide, head injury trauma. Most important, drugs, alcohol. Why
Yes,
would somebody go and touch the live wire? Either it's an accident, or if he has done by heroic thing, then he is not in his sense.
Yes, sir. Intoxication.
Drug is also important. Hypovolemia, shock, and not to forget in any of the case who is presenting hypoglycemia.
Yes, sir.
So if the patient who is not conscious or low GCS, these are the 4-5 things you need to rule out. Okay. Right. Next.
Go ahead.
So coming to the personal past history, the patient doesn't have any history of diabetes mellitus, tuberculosis, bronchoasthma, hypertension, or stroke. He was operated for the right elbow fracture 6 years ago. Personal history is the patient is a railway worker with vegetarian diet, regular bowel and bladder habits, non-alcoholic and non-smoker. There was no history of any allergy or any.
Sorry to interrupt. I will be trying to cheeky here. How did you get this history of his? He had a regular bowel and bladder habit. Otherwise, you had no other history with him.
The mechanism of injury is not available.
Yeah, I understand that. But you specifically wrote here he had a regular bladder and bowel habits. You said you couldn't get more of a history, but you could get his bladder and bowel habit history.
So it was in the initial checklist was there when the patient comes to the ER. So it was normal bladder, bowel, non-alcoholic, non-smoker, non-tuberculosis, non-diabetic.
And so again, in a history, when you present a case with a burn and a kind of emergency mechanism of injury because there's nobody available, but he was competent enough to give you bowel and bladder habit history. It's kind of makes us, Dr. Joshi is saying, it makes us a little bit of cynical about the whole thing. So either don't present this, advice is don't present this or gloss over it. You don't have to be, this is a medical history which is not needed right now. I think his bowel bladder habits before, he's a 27-year-old man. I don't think we expect anything for him to have a CA colon or a BPH to affect him at the age of 27. So fair enough. We'll gloss over it for the sake of time.
Yes, so the treatment taken outside was dressing over the burnt area was done, and exact treatment is like the documents were not available for us.
Transfer.
Go back. Treatment taken, dressing over the burnt area was done. History of treatment was why you couldn't get a history of treatment taken? And the discharge summary, you said it was written, right? So they must have written what discharge history they must have given.
So the patient is already discharged from a hospital, sir. So all the documents which, pardon, sir?
Discharge summary.
Sir, actually, this treatment was, we are talking about the treatment he has taken outside
the hospital.
I understand that. But why you couldn't get it? Because either you are discharge summary or they must be having, you could have picked up the phone and called the person who had treated.
No, sir, the patient is from is railways, sir. So all his relevant documents are submitted with the railway, sir, including his first CT scan, which was done outside.
But you know which hospital he has come, right?
Not the name, sir, because we don't
know which hospital he had come from.
No, sir, we don't know the name of the.
I think I'll answer that. So I don't think the line of communication between two government hospitals or between a government and a private and a government are that very good in our system.
Very good.
So yes, we expect some amount of history to be lost in transit, line running or something like that, and that's about it. And some scribbled note from a medical officer in a district hospital or a railway hospital. So fair enough. I don't think that this is where we lack, where we're not able to communicate. But yes, if it had been a private hospital to private hospital, it's easier to call and find out, or in a government hospital where you know which section, which surgery department or where he came from. But from a district small railway hospital to let's gloss over it for the time being. But yeah, but I think what Dr. Joshi is trying to communicate is either you present no history and make it a veterinary case and say, we have nothing on this guy and we're going to move forward. So you cannot put a little bit of like, some history which you want to, which cannot be counted, which is irrelevant, bowel bladder habits, vegetarian diet. I really don't care what he eats at this point in time. So at this point in time, I will care a little bit later, but so that's what we're trying to hear. You have to be focused even in your presentation, especially when you give a DNB Viva. When you gloss over these things and you take the patient and you're just going to distract all of us towards bowel and bladder habit.
Yeah, absolutely. And the another thing I wanted to come to is
So
you are the second responder from the previous one. Again, assuming because I have gone through your previous slide, next slide, so that's why I can take a liberty to ask. What would be your approach if you were in ER or you were called by your ER colleague that such and such patient has come in who is unconscious one? So what are the historical points you would like to know if you had access to his full thing?
Perfect. So the question is very well framed. So if you are the secondary responder, how will you do it? What history is relevant rather than bowel and bladder habit?
So, the history of if the patient had had a fall,
You have to know.
Yes, sir. So after the fall, the time of if the patient was unconscious or not, the time duration of loss of consciousness. After that, whether the patient suffered from any bleed, say from nasal bleed or ear bleed. After that, whether the patient had any kind of vomiting, abnormal body movements. Then. Did he suffer from any pain, especially the cervical neck pain? Was he able to move his limbs, upper and lower limbs? And so these things, if the patient is conscious, these history must be asked from the patient, sir.
Just two more points to ask, to add. One, obviously, if there is an electrical injury, associated fire is there or not, whether that injury happened in a closed space, like there was an electric short circuit and the whole house got burnt in, and where he was brought out from the closed space, how long he had been exposed to that closed space. So that is basically associated inflammation, burns are also there or not. Any first aid was given to that person or not, whether it's an electrical or any other kind of burns. And this might be difficult, you might not get, but if it's an educated person or a educated family, whether this gentleman had any tetanus booster dose taken or not. So these are the 5 points, 4 or 5 points besides what you have taken history you should add on.
Yes, sir.
Right, next.
A little bit more history on the fall in this guy. How did he land? Did he land on his legs?
Yeah.
So mechanism of injury, the protocol of approaching the injury has to be obtained at whatever situation, whether you are receiving him in the ICU after the ER has already evaluated you. You just have to write on your history sheet as a critical care physician, what is the mechanism of injury? Because a fall from height of more than 15 feet would make your Canadian critical spine rule not valid.
Yes, sir.
Isn't it? So you now have to clear the spine in a different way as compared to a fall who is just a thermal injury and who's awake and alert, who can tell you there's no distracting pain. So this follows the Nexus criteria, C-spine criteria, whatever it is. Everything will go awry if you don't know what exactly happened. So if you had a loss of consciousness in that closed environment, was there what kind of a factor? If it was a closed environment, what kind of it? So the classical exam question is a photographic factory, or something in which there is silver cyanide. So because you're worried about cyanide poisoning or in a burn system. So there are so many issues. I think what we really want is the detailed mechanism of injury, like a police will construct a case. What exactly was that guy doing, and how did he fall, and what was the circumstances of the fall, and what exactly was the situation around it. I understand fully well how much saline he received outside. Those things we are not going to be getting in our country. It's very difficult whether he got a cefotaxime or ceftriaxone or piperacillin. We really don't worry too much about it that way. Tetanus toxide, you don't want to repeat it. So if somebody can tell you, it's great. But that's about it. But the mechanism and the story around it has to be really well built. So it cannot be just that road traffic accident. Where was he? Was he wearing a seat belt? What was the car driving at? What was the high impact? Small, if it's a 25,000 volt, that's a perfect history. You've got a history that he touched a 25,000 volt. Similarly, it might be, so that is the most important thing in the history, the mechanism of injury. Go ahead.
And it has got all the relevant things associated with it because it impacts your future management. Including whether the patient has received first aid or not.
Yes, sir.
Go ahead.
So, sir, the general examination was done. The air.
Yeah, go ahead.
So yes, sir. So the general examination was done. The heart rate was 110 per minute. The blood pressure was 120/70 mm of Sg. The saturation was 98% on room air. The respiratory rate was 20 beats per minute, 20 rate per minute. Pallor ictus was absent. The sugar, the blood sugar was 97, and the temperature was 98 Fahrenheit, sir. So the airway was patent. The patient was able to hold his neck. So as per the nexus criteria or Canadian C spine, the cervical injury was ruled out. The breathing air.
Stopping is okay. You said when he came, he's already day 3, right?
Yes, sir.
So do you still want to go ahead with this nexus criteria and Canadian criteria? Point number 1. Point number 2. What is staggering here that would negate the use of this criteria? You know what is nexus criteria, right?
Yes, sir.
Right, go ahead and tell the next criteria.
Tell the nexus criteria. I think there are 4 points.
5, sir.
Yeah, go ahead.
So no posterior midline tenderness, sir. No level of intoxication, sir. No any painful other injuries, sir. No neurological deficit, sir. And alertness is normal, sir.
What can you elaborate? What do you mean by other injury?
No painful distracting injuries. No?
Yes.
So isn't the burn a painful distracting injury?
Yeah. So classical word, as sir says, is no distracting injury. He has fallen from the height. You said he had a severe shoulder and a back pain, right? This is a severe distracting injury. Till that is addressed, you cannot rule out his C-spine injury.
Because according to the Canadian critical care, Canadian C-spine rule, you would have to do it because he has fallen from 15 feet.
Yeah,
yes, sir.
exactly.
So you have to do a C-spine if you haven't done it before. So I don't think you can rule it out. In fact, you're wrong. If it is just a burn, I can understand. But even then, it will be a significant distracting, painful injury where his, especially wherever the body, we don't know where it has touched him, whether it's legs or where is the burn injury. We don't know as of now because you haven't mentioned where it is so far in your this thing. It's not in the hand is the only thing I know so far. But what I know is that he has fallen from a height which is more than 15 feet to get a.
So essentially, as sir said, that this you cannot rule out cervical spine injury. In fact, in other countries, it will be like you can be sued for this. So when you know the criteria, you need to know every component is extremely important. And one of the biggest component here, which is most of the time neglected, is a distracting injury. Burns is a major distracting injury. Fracture is a distracting injury. Any other wound is distracting injury. Head injury is a distracting injury. So you should not have done that.
Yeah, both the nexus criteria won't apply and the C-spine cervical injury won't apply. So I don't think it is right to rule out C-spine without imaging. What imaging would you like?
What imaging would you like?
Except cervical spine X-ray, sir.
What does the criteria says? You read the criteria?
Sir, there is X-ray. So lateral view X-ray, and then sir, there is
Okay, the criteria suggests to do a CT scan. And if the CT scan cervical spine is normal, you have to at least have to take 2 or 3 second opinions, as every institution has a protocol on that. So either you do a CT scan with a very thin slice, multi-slice CT, and have a secondary opinion and reevaluate the patient, or if not, still in doubt, you have to do an MRI. Till then, you cannot rule out the C-spine injury. Basically, you shouldn't be removing the collar. There is no, at least to my
So
knowledge.
the answer is very simple. The preferred imaging of choice is a CT scan in an exam, in real life, whatever it is. All right. So obviously it is a high risk. A low risk can be used clinical rules, Nexus and Canadian C-spine, or a combination of both. Because he meets the high risk criteria, not because of the fact that he's fallen, he's got distracting injury. So both are not applicable. Therefore, the procedure of choice in any emergency room or any ICU is a CT C-spine. That is what we need to hear from you. And subsequently, whether MRI and all is required, we will discuss later. But I think your answer should be that CT is the preferred method of diagnosing C-spine injury as of today. There might be availability issues. I understand that in certain places, but CT scans are pretty much available in every hospital. Anybody, at least where you're doing a DM, it is available.
Yes.
All right, go ahead. So A is wrong.
So then breathing, air entry present, bilaterally air entry was present, circumferential burn was present, but his chest expansion was symmetrical. Respiratory rate was 20 per minute. Saturation was 98 on the room air. So circulation, the blood pressure was 120 by 70 mm of Sg. Since his peripheral venous access was difficult, right femoral catheter was inserted, sir.
Sorry, what you will see in the circulation? Particular to the burns, 1, 2, particular to electrical burns.
The other way, is the circulation assessment adequate?
Yeah.
Just a blood pressure, is it adequate?
Blood pressure is adequate. And plus, you have also mentioned an important thing in your breathing.
Sir, in case of electrical burn, sir, we need to rule out any cardiac anomaly, like cardiac, any ECG changes, sir.
Of what?
So any arrhythmia, sir?
Which arrhythmia? He is coming day 3 to you, right?
Yes, sir.
Yeah. What would you be expecting in an electric injury that can cause electrical cardiac disturbances or ECG changes on day 3?
Sir, hyperkalemic changes, sir.
Correct. That's one. And second thing, what else in the circulation in particular?
Pulses.
Especially peripheral.
Peripheral pulses, sir.
Can you elaborate more on that? What's the importance of circumferential burns in this?
Sir, whether the patient has had any compartment syndrome, sir.
How do you look for it?
Sir, there will be pain, especially in passive movement.
So you look for a capillary refilling. If your hemodynamics are stable and your capillary refilling in that particular area is very, very less, then there is something going on. Or otherwise, the classic 4 Ps: pain, paresthesia, pulselessness, and paralysis.
Also,
That's very, very important. especially when you're looking at any burns or especially the circumferential burns on that. What else in the breathing you want to look?
Sir, any hoarseness of voice, sir?
Mhm.
Uh,
For
Sir, to rule out, sir, inhalational injury, sir.
good. Let me tell you. Tell me, how will you rule out inhalational injury? Not completely, but what are clinical findings of inhalation injury you will look out for in this patient, assuming he had a fire. He was in the fire and all the things. For an inhalational injury, how will you look out for? Tell me points in history and examination.
Sir, coming to the history, sir, whether the patient has had the burn was whether the incident was in a closed room or not, closed space or not.
Correct.
Then, sir, there will be whether there are signs of facial burn around the face.
No, the history. Don't jump on examination.
Duration of exposure, sir.
Duration.
Correct. So whether he was in extended stay in that area. Correct. Third.
Whether there was unconsciousness followed the event, sir.
Okay, fair enough. That's fine.
And
altered more than
20%.
More than 20% total body surface area burn is there. Then and in adults and more than 10% in children, you should suspect the inhalation injury and exclude otherwise. History.
Yes,
okay. Examination.
Burn around the facial or oral face or oral cavity, sir.
Correct.
Blackish colored sputum, sir. Charred colored sputum, sir.
He had gone a little bit far. Just go a little bit. Stay around the nose. Burnt nasal hair.
Burnt nasal hair, sir.
Singing of hair,
Edematous.
that is called.
If you are
Singing of hair, blackened hair because of burn, and soot in the hair, soot in the nasal cavity or upper airway. So soot is carbon deposit, and singed hair means hair is burnt, black and burnt. So if you see that, then you know that there is a mistake. Remember, edema and stridor is a late sign. That is going to happen after you basically pre-arrest. So you don't have to wait. You can't wait for that, and that's never a part of your examination. So it's basically examination of the upper airway and lower airway. Obviously, focal crackles, if there are any, or wheezing, any focal wheezing would tell you something.
So you have to go upper and the lower airway. These two things. And by the time if you say hoarseness, breathing difficulty, you have already missed the bus. Your airway edema has gone to such an extent that you won't be able to intubate also this patient. You'll have to go to probably see straight away front of neck access. So you have already missed the bus on that aspect of it. So intubating an upper airway, securing the upper airway you have said patent. But
yes,
if the patient has already developed this, then you have already missed the bus. So that's he will get in, he will arrest straight away. Okay. So airway, breathing, circulation, saturations. What else?
So 98% of cases.
Sorry.
98%.
Saturation is 98%.
Yes. What's do you have to importance? Do you feel it's okay? Or suppose you were first responder, will you give him oxygen? Or
yes, sir. 100%.
wait and take the history and look for the saturations.
No, we'll start with 100% oxygen, sir.
Why?
Sir, in case of carbon monoxide poisoning, sir.
Yep.
So the saturation, the SpO2 will still be normal, sir, in those cases, sir.
Not sure on that. But any case, why it's important for a burns patient to have oxygen in a suspected inhalation injury? You're right. It's about carbon monoxide poisoning. But what's the real reason for that? That irrespective of whatever it is, you have to give him an oxygen.
Sir, because carbon monoxide's binding capacity to hemoglobin is more than oxygen, so the delivery of oxygen will be less to tissues. So
Yeah.
and
How does oxygen help?
sir, by continuously giving oxygen, sir, with time, sir, the carbon monoxide is replaced by oxygen, and by inhalation, it
For your level, you should be telling the half-life of the carbon monoxide. So how is the half-life of the carbon monoxide different? In a room air, it's almost like 250 minutes. If you start giving him 100% FiO2 on non-rebreather mask, it comes straight down to around 50 minutes. If you want to further decrease it, you have to give a hyperbaric oxygen.
Hyperbaric.
2025. So giving a oxygen, that also not 6 liters, 10 liters, you have to give a non-rebreather mask in this patient if he's breathing spontaneously.
So oxygen is the best treatment for carbon monoxide poisoning. That's the answer in a very simple way. And why is what we have said? Because many of the ABG machines do not have a co-oximetry.
Yeah.
And your SpO2 will not be there. So in a lot of hospitals, you will, if you go to work outside of a big center, you will not have a co-oximeter in your ABG, and a standard ABG won't be able to tell you whether there is a carboxyhemoglobin or not. So it is better if you are in a district and periphery, as we get a call as a DM receiving, as a consultant in critical care receiving a patient from outside, you say put the patient on oxygen and then send us. And that's something is very important because they don't have the ability to do a co-oximeter on an ABG. All right, go ahead.
Next.
Coming to disability, the patient was conscious and oriented. GCS was 15/15. His APVU was alert. The patient was alert. So exposure, the percentage of total body surface area of burn was 40%, sir. So depth of the burn was partial thickness burn. He had received tetanus boosters. So.
Okay. So this was like on the day 3, but suppose you were again the first responder for the burns injury, any kind of. What is your broad approach to this patient? How would you approach with the? This is a combination, right? This is a combination of burns with trauma. So how would you go in as per the ATLS guidelines? This is a trauma, right?
Yes, sir.
So how do you approach a trauma broadly? What are the surveys? 3
After ABCD.
So you have
So
a primary survey.
Primary survey, sir.
And then you have a secondary survey.
Survey, sir.
Right? So one of
Yes,
the
yes.
things remember is which will slightly deviate from the ATLS thing of a primary survey and secondary survey is primary survey, FAT, and secondary survey. So the primary survey you are done airway, breathing, circulation, deficiency, exposures, right? So you add for particularly if there is associated burns, what we call it as a FATT, FAT in between, fluids, analgesia, test tubes. Okay, and then you go to the secondary survey. This slightly get changed from the regular trauma. Fluid, analgesia, what are the blood tests you have to do? So this is what you will see in if you are in an ED or if you are called in ED and you are a first responder. You do this primary survey, you do airway with spine precautions, ensure that it's okay, breathing, 100% oxygenation, give it today, looking for the facial injuries, look for the circumferential, look for the circulation, peripheral circulations, circumferential and things. If there is circumferential burns, then your algorithm goes to a different D, deficit, GCS, alcohol, drugs, head injuries, brain trauma, and then come to the exposure as a part of the percentage burn, and then further calculate. Once you have done this, you go for the fluid. As per, we'll come to that. You have to look for the analgesia, which most of the time in India we don't do that. You have to send the test, and then you have to put in the lines and tubes immediately, because by the time the edema comes up, you have lost all the chances, right? And then once you get the test and tubes back, you look for a secondary survey where you will have a more detailed survey as per the ATLS. Okay, so these I have to remove the fluid, analgesia, test and tubes. And if you are not done that in the primary, and if you are a secondary one, you need to try to get at least this information. So what is the information regarding the fluid resuscitation you want to do? You want to take for this patient?
Sir, whether he has received resuscitative fluid in first 24 hours after the burn, sir.
How much?
Sir, according to Parkland formula, sir, 4 ml per kg body weight multiplied by the total burn surface area, sir.
Suppose you have given there,
and then 50% of 15% of it in first 8 hours, and remaining 50% in remaining 16 hours, sir.
Okay.
If somebody comes on the 12th hour and has not been resuscitated, what do you do?
Sir, again, in that case, sir, we will give the calculated amount of fluid in the 12 hours, sir.
Okay. So what we suggest is that you should use in this situation, not only use the Parkland formula, use the nomogram and just put a scale and see how much is the catch-up fluid, and the rate will come out. All right. So you have to have a catch-up this thing. Any other formula that you know other than Parkland?
Sir, there is modified Brooks formula, sir.
How much is that?
2 ml per kg, 2 ml multiplied by body weight multiplied by burn surface area, sir.
Any other rule?
Then there is, sir, 10% rule of 10 is there, sir. So a total burn surface area is calculated, and it is brought to the nearest 10, sir. And then it is fluid is given.
Then multiply that with 10 per hour.
Yes, sir. Per hour, sir.
So 40 into 10, 400 ml per hour would be what you would do for the first 24 hours.
Yes, sir.
So he has come after 24 hours to you. What else you would be looking at? So afterward what? Once you have given this percentage total body surface fluids you have given, resuscitated. Afterwards what? After 24 hours what? How will you manage the fluid? Important. Which fluid you will give?
Why NS? With this amount of volume.
Sorry, sir.
So what will happen when you give large quantity of normal saline? Does it become abnormal?
Hyperchloremic. Solution will be hyperchloremic, sir.
Do you want that?
No, sir.
What do you guys use?
Pardon, sir?
What is your normal fluid? For in your IC, so if somebody comes to the emergency right now, what would you give? Normal saline or Ringer's lactate?
Ringer's lactate for burn.
So for a non-burn patient, sir?
For burn patient.
Sir, Ringer's lactate, sir.
So no albumin? You don't want to give albumin?
Sir,
just asking.
No, sir.
Most of the studies most of the burn studies are done either in the normal saline or the ringer lactate solution. So, of course, as sir said, there is a theoretical disadvantage of getting into hyperchloremic acidosis. But in absence of the availability of any other thing, normal saline is sufficient, and you need to keep giving the normal saline. So the second question was, once you have resuscitated him with the saline, how will you determine the further fluid requirement? Because these people will have a massive surge response. Massive means massive, and you cannot stop that. These people they just
Goals of resuscitation.
Sir, our goal will be it will be depending on the urine output, sir.
Yep. And
so
Perfect.
It will
So how
lactate
much?
and urine output.
pardon, sir.
Lactate and urine output. Primarily urine output, but you can also get supported with lactate and other acidosis.
Yes, sir.
Okay.
Then mean arterial blood pressure, sir.
That might not be the requirement, as long as your urine output is okay.
Yes, sir.
Or at least 30 ml per kilo, 25 to 30 ml per kilo. That means you know that your kidneys are perfused well. That should be enough.
Urine output, CRT, the cheaper ways of hemodynamic monitoring, and volume of pulse in the non-burnt area where you can see. So I think, yeah, so just using CRT and urine output is probably the best and the cheapest method to do hemodynamic assessment and fluid requirement. Always remember that if somebody is urine output drops, it's not necessarily always volume problem, but yes, that is going to be a number one criteria in a burns patient for giving more fluids.
Like obviously you are suspecting any obstructive uropathy. Okay, in this patient, why again urine output is important? Or why the renal parameters are important? In this particular patient.
Sir, to look out for myoglobinuria, sir.
Yep. Because of? Or leading to?
Leading to AKI.
AKI. Why would AKI occur in this patient? Which one is?
You already answered it first.
I think you answered it before.
It can be this.
Sir, can't hear you, sir.
Okay. Why would this patient have AKI? Did you say just now rhabdomyolysis?
Yes, sir.
That you guys did.
Yeah.
I remember you guys saying rhabdomyolysis.
Yeah. So why would this person gets a rhabdomyolysis? This particular person.
Sir, since it's a electrical burn, sir, there can be there is and the electrical burn can lead to bony injuries, which can disrupt the surrounding tendons and muscles, sir. And the patient has already presented after 3 days, sir.
What is a good conductor of electricity or a bad conductor of electricity?
So bone is a bad conductor of electricity, sir.
Are you sure?
Yes, sir.
What are the other organs?
Sir, water is the best conductor of electricity, sir.
Particularly
so blood vessels are the better is a good conductor of electricity, sir.
Okay. So does it make a difference? I'll go back to the history in this. Is there a difference if somebody gets a shock from the home electric current versus getting shock from the high voltage electric current?
Yes, sir. The home electrical injury comes as it is 220 volts, sir. So it comes under minor electrical injury, sir. Anything between 220 to 1000 is moderate, and more than 1000 is high volt injury, sir. So this is a high volt injury.
Why we need to know that? The mechanism of the passage of such a high voltage of electrical injury, when it's 25,000, it doesn't matter. The minor aspects are doesn't even get counted because it is such a high. So it goes into a massive conduction. The body becomes one conductor from one place to another place. And when it's going it's going to go through the least resistance pathway, skin, muscles, and wherever there is a high resistance, you are going to get more concentrated energy there. So when you go that, there is a massive destruction of the muscle all over the body. And there is a massive rhabdomyolysis, hyperkalemia, and you tend to get into rhabdomyolysis and AKI. This is particularly true for a very high voltage injury. And hence, for a rhabdomyolysis, which may not ensue immediately, may or may not ensue immediately. So under resuscitation, rhabdomyolysis, myoglobinuria, AKI, hyperkalemia, cardiac arrest. And then you're wondering why my patient has gone in cardiac arrest, even though ECG was okay.
Yes.
Okay. So it's very important in this case to know the urine output. So once you have done the primary survey, I think we should move on this. You have given the fluids, you have discussed the fluid resuscitation, when you are first responder, when you are in the subsequent responder. What after the fluids we want to look into?
Sir, if we are the primary responder or the secondary, sir?
Irrespective of that, now your fluid resuscitation is done, primary survey is done. What else?
Then
primary survey FAT, FATT. Right?
Sir.
So do you think analgesia is important?
Analgesia, yes, sir, analgesia, because sir, the patient will be requiring multiple dressings, sir. And even for the examination, since burns are very painful, so even for any kind of examination, analgesic should be started, sir.
What are the preferred analgesics? How do you approach a person? How do you approach a person with the pain in your ICU?
Sir, we start with acetaminophen, followed by NSAIDs, and followed by opioids, or combination of these.
Will you be happy to start NSAID in this?
No. I think that standard thing for burn, partial thickness and above. Do you think paracetamol will? Is that right? Is that how this is a standard? What you're saying is an ICU pain where patient comes in and you look at the pain scale or the CPOT score and you give them less than 3. You expect you said partial thickness more than 40% burn. By definition, when you have partial thickness, you have excruciating pain, isn't it? Only when it becomes burn it down all the
opioids will
have analgesia. Partial thickness is the analgesia of choice is what? Is always a
opioids, sir.
Yeah, narcotic.
Narcotics, opioids, they are the highest, best, and most preferred. And then you go ahead beyond that, because these patients will not only doesn't stop at the opioids. You have to load them with the opioid. You have to look for the other alternatives. You might have to go to the level of ketamine, especially during the things. And you may use sometimes the gases, methoxyflurane or anything, if it's a severe excruciating thing, especially during the dressing. Sometimes these dressings have to be done in OT for a reason. It's a very, very, very painful procedure.
So the answer in the exam should be very simple. Don't beat around the bush. If somebody says pain management, answer should be IV morphine or fentanyl, whatever is your preference, but a narcotic. All right, preferably morphine.
And beyond that, multimodal therapy or multimodal approach.
So that's a simple way of answering, and don't do this stepped up model of WHO pain management with burns.
Yeah, in burns it becomes a little bit different.
Go ahead, move ahead.
Then, sir, as you said, sir, with the case, sir.
Yeah, with the case. So with the case here, okay, you've gone to systemic examination already. So in between, you do you want to send some tests?
Yes, sir.
If you are a first responder, you will be sending
Yes,
some
sir.
tests. Yeah.
Yes,
So
sir.
what test you want to send? You are a first responder.
So, sir,
Primary survey, fluids, analgesia. What test you want to send?
so complete blood count, sir. Liver function test, kidney function test, sir.
Hmm.
Coagulation profile, sir.
Why? I mean, you're right, but why? Any specific you're looking at?
Yes, sir. Any derangement, sir? Any previous derangement, sir?
27-year-old.
Already.
Anyway, go ahead. Now, what else?
Sir,
You already spoke. Himanshu spoke something. No, Mohit.
so,
Sir,
ABG,
ABG for lactate, sir.
arterial blood.
ABG for lactate and acid base and electrolytes.
Yes, sir.
Anything else you want to say? If you are a first responder? If you are in a posh
City.
Mumbai locality, young male, super rich. Drugs and alcohol level, please. Don't forget that.
Yes, sir.
And urine routine and myoglobinuric.
Yes.
Now, in this particular case, which has an associated trauma scan,
Yes, sir.
and
Yes, sir.
in ED, if you want, you can do a fast scan or anything, whatever it is. So don't just get distracted with the burns. Also give a other approach. Fine. Next.
Coming to the systemic examination, CNS.
Next slide.
Yes, sir.
Did you do the
Patient,
secondary?
Pardon, sir?
Did you do the secondary survey? You had a primary survey. You had
Again,
a
you're
scan.
forgetting the case as burns or trauma. So I think this is a burn trauma. So either
Yeah, because you presented with the burn trauma. You said that
just kept him at an electrical
Oh.
injury. Yeah. You should not have made him fall from the height. You should have just let him.
you should have just shocked him. Anyway, in terms even
Secondary ground.
the electric burns along with that, assuming this is either electric burns or other burns, in a secondary survey, even for the burns, what are the specific things you will be looking at? Because it has a direct impact and you are a first responder.
So history of any allergies, medications, any past medical or surgical history.
Agreed. Next.
Last oral intake, sir.
Why? Anyway, okay. Next. Not relevant. Just particularly from the burns perspective, you should be looking again for the in detail for the circumferential burns or any compartment syndrome developing. And if there is a circumferential eschars have been developed, this patient should be immediately taken to the theaters for the escharotomy.
Yes, sir.
It is very, very important. Do not forget that. Just looking at it, you need to act on that thing. So everything goes to the side, and the precedence goes to the patient is going straight to the theaters and do the eschorotomy. Otherwise, he will lose his limb or whatever the circumferential thing is there. Also, we tend to forget that the abdominal eschars also can cause increase in the intra-abdominal pressure. So if you see a circumferential burns around the tummy, around the chest, around the lower abdomen, you have to roll the patient to the back. Log rolling, you have to do it. Look for circumferential thing. And if we're suspecting that, just go ahead, because one of the cause for the renal failure can be increased abdominal pressure. Plus, you are resuscitating him with such a massive fluid thing. So it's going to be edema, and all over the place. So this patient needs to go straight to eschorotomy. You don't have to wait for the next day morning. He will be dead. His organs will be dead by that time. So secondary survey is important. So primary survey, fat, and secondary survey are very, very important. Lines, tubes, intubating early if suspected. NG tube, putting the NG tube early is if you are suspecting. Urinary catheter. Just because he looks all right, you shouldn't. Especially in the electric burns, where the injuries are very, very concealed. And by the time you know it, you should have an extremely high index of suspicion, especially for the electric burn, because externally you may not see much of the things. All right. Local examination. Yep.
So the patient had extensive second-degree burn over the chest, back, and bilateral upper limbs and the back. His burn surface area was approximately 35 to 40%. Outside investigation which was done was NCCT of head. It suggested of communicated fracture of the frontal bone, fracture of the room and lateral wall of sphenoid sinus with pneumocephalus. So the investigations sent for ABG, complete blood count, LFTs, kidney function test, electrolytes, PTINR and APTT, viral markers, urine routine, CBKMB, chest X-ray, ECG, X-rays of the right and left shoulder AP and lateral view, and also of the AP and lateral view of the elbows, CT head, USG whole abdomen, and orthopedic and plastic surgery opinions were taken. Sir.
Okay, next.
So the provisional diagnosis is a 29-year-old male with electrical burns and traumatic brain injury, sir. Treatment initiated, sir.
Now you have to explain me every treatment you have given.
As per consultant, as per orthopedic, as per nephrology, as per neurology.
I will really suspect, I will appreciate the nephrologist if he's giving amicus in here.
So dangerous thing to do, isn't it? Why would you add nephrotoxic drug, and what advantage do you have for adding metronidazole to piperacillin tazobactam? So you can divert the exam completely to antibiotics and make your life miserable.
This is one aspect of it, the case presentation aspect of it, but also as a DM candidate, when you are a consultant,
right,
explain it. Why you need piperacillin? You said he's hemodynamically, he's normal. You're saying that he's fantastic. His GCS is 15. His airway is patent. He's 98 saturations on the room air. He should be sent home or to the ward. Why he should come to the ICU? And plus, all are injectable.
Yeah, and it doesn't require so much of antibiotic. It doesn't require double gram-negative anaerobic and double gram-negative coverage, double anaerobic coverage for no burn sepsis. So the question is, electrical injuries, heat coagulation happens. I don't think anybody survives at 25,000 volts, including your bacteria. So nobody survives that. So it is a sterile thing. Yes, you have been in a gurney, you have actually coagulated most of these things there. So you can get away with a super ANSEF kind of a thing, a SuperSEF kind of a thing. And this, if you really have to give something, but otherwise there is no role of antibiotics in burn sepsis. But I agree with plastic surgeons and orthopedics, ICU physicians have not much of a choice. But then you have the ability to strike down. There is no reason to resolve that peptido won't cover. And why do we require double? Don't have any proof of Pseudomonas or anything to say that you need double gram negative. So if you have to commit yourself, you might at least avoid a nephrotoxic agent. You might avoid drugs which are going to cause you problems of QTs and things. So at least be nice to the patient.
And the second question was levetiracetam and phenytoin.
Traumatic brain injury, prophylaxis of seizures, 2 drug recommendations.
That's a different, completely different
Absolutely.
topic and
So,
discussion.
yeah, no, I think so. What happens in an exam is this is what happens. So in a Viva, in a DNB, the topic you might be prepared very well for the burns, but then I might take you towards this and then you get flummoxed. So be very careful about what you present. Sometimes it's okay to say, I don't agree with this. Fair enough to say I don't agree with this and say, as a tramadol as a weak opiate is a very poor choice of analgesic in a 40% burn. If you're giving an opiate, feel free to give. So I would actually say, none of these drugs are actually something which should be given or should be initiated by any one of us. All right, we can actually strike off everything. I have pantoprazole, IV, maybe, yeah, with the link ulcer, but, burn patients have this thing. But other than that,
Early feeding takes care of it.
Yes, sir.
And then you're written fluid at 80 mils an hour. So you have to justify that. Why 80 mils an hour? Because the urine output was normal. Did he had any urine catheter?
Yes, sir. Foley's catheter was inserted, sir.
Okay. So
you're
treatment
not doing
wise,
by mouth, is he?
yeah, be careful on this. When you become a consultant, make sure that you don't have this list on your thing.
Yes, sir.
Okay. Next.
Actually, this is the easiest patient to manage in the ICU. There should be no medicine on him.
There's no medicine actually. Let him eat, drink, whatever you want. He doesn't have an inhalation injury. He should be able to eat.
Correct. And you should not be allowed to come into your ICU.
Yeah.
So anyway, so now that the patient, it's just a case presentation, we agree. Move on to the next slide. We'll not disturb you here. We don't want to distract. This is distracting injuries.
No, we don't want.
So the neurosurgery,
Fine, go ahead.
orthopedic.
Yeah, go ahead.
Fair enough.
So the focus was done, sir. His ejection fraction was normal, sir. No LV systolic dysfunction was there. No pericardial effusion was there. The lung sliding present with the A profile in all the quadrants, sir. There was no pleural effusion, sir.
Why did you do focus? You could have done a formal echo. He's already in your
Yes,
ICU. Not unstable.
Sir, the formal echo was advised, sir. But
See, when you are using point of care ultrasound, there are specific indications. They are used to be used in an emergency. They help you to aid your diagnosis. And you already scanned top to bottom. You have a lot of access. You have everything with you. Why you want to do this focusing? Just because to practice, that's a different.
Focus should not say EF 55 to 60%. Say good ejection fraction.
Yeah, exactly. You're
Good, bad, or ugly, and just leave it like that. Again, normal LV systolic function is part of the. Anyway, so I think, yeah, you don't put the echocardiographer out of business. So it doesn't require anything. There's nothing for us to really look at. We don't expect him to have a valve. So if he has some problem, it's going to be. There's no reason to do it. Okay. All right. So you've done it. Don't gloss over it.
Yeah.
All right. Next slide. He's all absolutely okay. He doesn't deserve to be in the ICU. We agree with you. So plastic surgeons are going to do the OT. Next one. All right. Anything abnormal on the hemoglobin? So you went too fast.
yeah.
uh,
Go back.
sir, the hemoglobin was 7, sir.
Okay.
Yes, sir.
So why?
And,
So why does he have such a low hemoglobin?
He's almost like a pancytopenia.
yes, sir.
Yeah.
TLC counts were low, sir. Platelets were 1.2 lakhs, sir.
So he's got pancytopenia. Why?
Yeah, platelets are also low. Platelets are low, hemoglobin is low, and white cell counts are low.
So is it just burn related, or is he now in? Do we think he's septic?
Sir, vitals wise, sir, he was stable, sir. Cultures were sent. They came out to be sterile, sir.
Okay. Did you repeat the CBC?
Yes,
Was the
sir.
Yes.
CBC the same?
Pardon, sir.
Was the repeat complete blood picture the same pancytopenia?
No, sir. It
No, sir.
improved, sir.
Maybe it might be a collection error. Most of the time, given fluid is going on and blood gets collected from the cubital fossa, so that might be the. And electrolytes were okay.
Yes, sir.
Hypernatremia.
Slightly potassium was on lower side, sir. And the patient was hypoalbuminemia was also there, sir. The albumin level was low, the potassium level was low, sir.
Right. Urea creatinine was normal, right?
Yes, sir.
Yes, sir.
Okay, next.
So the cultures were sent, sir. So they came out to be sterile, sir.
Mhm.
So these are the investigations, sir. The chest X-ray AP view.
Do you routinely send urine for culture for everyone?
Sir, if the patient is being admitted to some other hospital and then referred to us in the suspicion of sepsis, sir. So we do, sir.
You're suspecting,
In
sir.
who is the patient hemodynamically unstable, then yes, sir, we do.
Don't try to send the culture blindly unless you're high index of suspicion. Otherwise, you will get random things and you will start treating the random things.
Yes, sir.
Be careful. At least send a CUE before. If there is a loads of puzzles, then you can send for it.
Yes, sir.
Don't get into that habit. Okay. Just X-ray. Anything you see?
So wound swab culture is generally bedsheet cultures.
It's
Pardon, sir?
Wound swab cultures are generally bedsheet cultures. You might as well culture your bed sheets.
spit and tube.
So if you want to prove tissue, this thing, you have to get a tissue culture per gram. That's the ideal way. But yeah, you agree with you that it's better to send wound culture from the OT by taking a snip of tissue and sending the tissue for culture. That's what you should encourage your plastic surgeons to do if they suspect burn wound infection, rather than to take a swab from the outside. The swab will grow in India, will grow as an Acinetobacter or whatever is the flavor of your hospital, or whatever.
Sorry, sir, you're not audible, sir. You're not. We can't hear you, sir.
Sorry about that. No, go ahead. Go ahead.
Yeah, we lost. We are not able to hear you, Ram. Anyway, go ahead. Next. Chest X-ray. Anything specific you are seeing? Anything on chest X-ray?
No, sir.
No, sir.
Next.
The X-rays of right shoulder, sir.
Yeah, that doesn't excite us. Go ahead. That orthopedician will take care.
Yes, sir. The right elbow, sir.
Yep.
AP and lateral views.
Yep.
The left shoulder X-ray, sir.
Yep.
Coming to left elbow, lateral AP view. CT head, sir.
Yep. So the one thing you guys should have done for this guy was the CT cervical spine. Okay, so that was missed in this case. Okay, go next.
So, sir, as we said, sir, the issues were 40% burn of total body surface area. There was pneumocephalus, hypokalemia, hypoalbuminemia, and pancytopenia was there, sir.
What about a traumatic brain injury?
Yes, sir. Pneumocephalus was there, sir, and
You had a fracture also.
pardon, sir.
I think you said he had a fracture.
Yes, sir.
Yes, sir. Sir, lateral wall of the sphenoid sinus, sir.
You could see I think okay.
So the issues in this patient should have been 1, burns, 2, traumatic brain injury, 3, whatever the electrolyte or whatever abnormality. You should, when you, as an intensivist, you should be more focusing on intensive care issues and the predictability of this thing. You should include the pain because that's going to be an issue in this, and most important, the nutrition, because they are in a severe hypercatabolic state. So that is also an issue that you need to address. And third is the prevention of the sepsis as much as possible. So burns with its resuscitation, analgesia, nutrition, and the associated injury management. So these are the 4 broad issues of for this patient. And you have to answer each of them now. Let's go. Next. What did you do for the burns?
So,
Go ahead.
sir, in this, so the patient was kept in isolation, sir. He was
No.
temperature.
That's not the way the patient was shifted to burns. No, that's not the soft act. So you have to be very particular because once this patient had come to you, you should give out the plan for this patient. Where is the analgesia plan? What is the food plan? How much protein he needs to be taken? How much carbohydrate he needs to be taken? That's it should not go. He should not go like that.
Don't be
If you-
superfluous about it. You have to be specific because you are the specialist.
You are the specialist. The buck stops with you. People should be listening to you. You should
So
have
the,
the
sir,
with your
So
own
oral
handwriting.
soft diet, is he gonna eat 400 calories or 4,000 calories?
so it will be calculated by 25 kilocalories per kg plus since he's a burn patient plus 40 kilocalorie per burn surface area, sir.
What are the
Then
other
how
ways
much did he?
to calculate the calories in this patient? What is an ideal way?
Sir, the division of you are asking, sir, the division of carbohydrates, proteins, and fats, sir.
No. How do you calculate calories? Where did this number came from? 25, 30?
So burn guidelines, sir. The guidelines, sir, suggested that.
It comes from, there are 3 broadly way to do that. The one which you have told is an empirical one based on the classic paper. I think it was in 1992, and that has been carried out and that has been used. Second one is ideal one is an indirect calorimetry. Not many centers do. I don't know in India how many do. Our centers do. It's very easy. It's a almost silly thing which I realized that it's so easy to do it. And the third thing is a formula for resting energy expenditure, which is extremely complex. And this has to be formulated and changed into, especially when you're using formula for the burns. But ideal thing will be an indirect calorimetry, which they put in a mask and then they try to calculate the oxygen and the carbon dioxide expenditure. There are more complex ways to do it, but these are the 3 broadly things. Based on that, you need to get your calories right. Based on the calories, you need to have also the proteins right. Okay, how much protein you will give?
Sir, 1.5 to 2 gram per kg body weight, sir.
Any
So protein has to be approximately 20% of the total calorie intake. The carbohydrates being approximately 50% and lipids approximately 30%, sir.
you can say that, yeah, okay, fair enough. That's fair. So when this patient was shifted to the ward, it was your responsibility to chart all these things. Okay, let's move on. Next.
So the patient remained hemodynamically stable and he underwent dressing by the plastic surgery team, sir.
So sorry, each dressing should have a chart from intensivist regarding the analgesia and the pain management, unless the anesthetist gets involved. So it becomes your responsibility as a follow-up. Right, next.
In your burn unit, do they do the dressing in the unit or do they do it in the ward?
Unit only.
Unit, sir.
Unit only. So do they have an anesthetist to man that unit or do you guys go and give it?
On-call anesthetists go there, sir.
So on-call anesthetist go. So if he uses ketamine or whatever he uses, that chart is available for you to review, isn't it?
Yes, sir.
Next. Patient developed irritability, irrelevant talk, and disturbance. What are your differentials? Day 5.
This is on day 5 or on day 13?
Day 13, sir.
Day 13. All right. So second week of illness, he gets irritable, irrelevant, and disturbed sleep. What's the differential diagnosis of what is happening?
Go with the obvious things first.
So there can be the patient can develop delirium, sir. There can be post-traumatic stress disorder, sir.
That's too early, yeah.
And it can be a manifestation of traumatic brain injury also, sir.
Correct. We had a traumatic brain injury, whether there has been any worsening of the injuries. That's one. Second, electrolyte disturbances.
Electrolyte imbalance, sir.
Electrolyte disturbances.
Yes, sir.
Third, you have to check the drug chart. Somebody has written the ketamine and then he had forgotten. And he's getting the ketamine and ketamine and ketamine.
Yes.
4, suppose he develops shock with irritability, irrelevant talk. What would you suspect?
Then we need to rule out sepsis, sir.
Sepsis 1, 2. Severe metabolic acidosis with rising lactate. Hemodynamics are stable. Blood pressure is normal. Everything is normal, but his lactate is rising. He's getting severe metabolic acidosis. He's getting irrelevant talk, altered sensorium. He starts becoming hypotensive.
What drug?
Assuming he's from, say, burns, proper burns, flame burns. How does cyanide poisoning present? So there is a possible, one of the differentials you have to think, especially in the closed burns, is the cyanide poisoning. They may come with a bit of a delayed presentation with altered sensorium, irrelevant talk, worsening shock, which you think that it's a sepsis, bad metabolic acidosis, even despite proper adequate fluid resuscitation, good urine output, your lactate is going up. The mitochondria are stuck. So you should think of a cyanide poisoning also, especially when you're dealing with a burns patient. How do you treat that? Cyanocobalamin. You 5 grams that. What's cyanocobalamin? Vitamin.
Burns means carbon monoxide poisoning and cyanide poisoning. These two questions will go simultaneously.
Yep. So you should suspect these things.
So always prepare for that. When you're coming for the Viva, a Burns case, know that the examiner will ask you cyanide poisoning either in the beginning or in the, and in real life it's important.
It's very important because we did everything and patient died. No, we didn't do everything because in that everything we have done antibiotics only and resuscitation. No. The cyanide poisoning is an important thing you need to keep in mind, and especially the burns, and read about it. Okay.
Yes.
Psychiatrist should come last in ICU.
And do you agree on post-traumatic stress disorder and clonazepam? Do you agree this is the treatment for the delirium if this is delirium? What is the drug of choice for delirium? There is no drug of choice, obviously. So this is delirium, and delirium is a medical condition, isn't it? So this delirium is a disorder of
Exclusion.
a disorder of inattention. So then you will have to irritability, irrelevant talks, and disturbed sleep. You need to go a little bit further. So delirium is a clinical diagnosis. So you have to. So what is the 4 things to diagnose? What are the DSM criteria for diagnosing delirium?
Sir, disturbance in, sir, previously the patient should be normal, sir.
So acute onset.
Acute onset should be there, sir. Disturbance in attention and awareness, sir. Reduced level of arousal, sir.
Not necessary. You can be hyperactive also.
Disturbed sleep, sir.
Sleep is not there in the diagnosis. The acute onset, fluctuating course, disorder of conscious, disorder of change in mental status, and inattention, or problems with awareness. So here, irrelevant talks and irritability and disturb. The only thing is relevant is irrelevant talks. So other than that, it doesn't tell me anything else about it. So again, this becomes a short case again.
Yeah. This becomes a completely different algorithm at approaching a delirium in ICU.
And delirium is a medical condition. So I would like to know what else is, what's his sodium again, what's his, before I give any treatment.
Pain, we forget pain as an important contributing factor. Urinary retention.
So the difference between delirium and pain causing this thing will be difficult to withdrawals, pains, everything. Maybe somebody stopped his morphine.
Yeah.
Maybe somebody gave him so you got a lot of things. So this again is when you write this, developed irritability, irrelevant talks, and disturbed sleep, nobody can form a diagnosis, or nobody should do anything at this point in time. All right. So yes, your differential is it just ongoing pain? Is he having with a burn, as Dr. Joshi is saying, cyanide and other complications of the earlier injury, a traumatic brain injury? Did he have seizures or things like that? And rule out all other medical causes. So that's what we will do before we give clonazepam every 12 hourly, or that's not what we want to do anyway. So ensure sleep, adequate pain, those are the things that would be do, and to treat delirium. Anyway, so go ahead. So this was not this is not in your domain. because this happened in the next slide.
So the patient was shifted back to the ICU on day 14th. There was irritability, irrelevant talk, and fever was there. But the burn wound was healthy and healing. So the pair blood culture, urine routine microscopy, and cultures were sent up.
And what has happened to the femoral line that you placed?
Sir, it was removed and it was changed to internal jugular, sir.
So he has a central line. So at this point in time, we need to know the devices also in your history.
So the day 15th, the blood culture was suggested of carbapenem resistant Klebsiella pneumoniae. So treatment initiated was polymyxin B and injection meropenem, sir.
Phenomenally quick growth and 24 hours must be hugely loaded.
Yeah.
All right. The CRE.
Pardon, sir.
Yeah, okay. Next.
So CT scan was repeated, sir.
Mhm.
And later on, sir, on 19th, sir, the patient developed recurrent episodes of vomiting. Continuous Riles tube aspiration was started. X-ray FPA was advised, sir. The USG abdomen was repeated and it was within normal limits.
What happened to the
The-
X-ray? The colonic pseudo obstruction.
Yes, sir. There was hypokalemia, sir.
This is on day 15.
Why do you say this is colonic pseudo obstruction based on this X-ray?
Yeah.
To say pseudo obstruction, what is the criteria? Pseudo obstruction is a specific thing. That means you have a particular diameter of a particular part of the large intestine to be greater than that in the absence of any obstruction, any physical obstruction, isn't it? So on this X-ray, I cannot see anything to say that this is colonic pseudo. I don't even see any. I don't know whether it's the visibility. I can't see any dilatation of large bowel. Cecum. The definition is cecal diameter greater than 11 centimeter, or I don't remember the exact
Yeah.
number, but it has to be something more than that.
Yep. Adynamic alias.
So you
pseudo.
cannot say pseudo obstruction unless you show me a cecum, unless you show me a dilated large bowel here.
I think if you faintly, maybe the picture is not clear. If you see on the left side and if you track, you can imagine bit of a hostation as seen. But still, it's hard to say it as a pseudo obstruction. So what did you do?
Sir, hypokalemia was treated, sir.
What happened to Lesuride?
So it was ongoing, sir. It was
Lesuride,
initiated.
you corrected potassium and Lesuride continued?
So later on it was stopped, sir.
What is the problem
Once
with
the
Lesuride? It's one of the most one of the common contributory factor for the delirium. It has a neuropsychiatric issues. So in a higher dose, or if you continue, it may contribute. So the choice of drug is not-
Parkinson's.
it should not have started, especially when you are dealing with a unresolved neuropsychiatric issues.
Yes, sir.
Anyway, so continuous Riles tube, X-ray, Lesuride, they discovered that it was a hypokalemia. Corrected, he improved. Okay, good. So he is now day 19 of his burns.
Yes, sir. Yes, sir.
So what happened then? What happened to his burns then?
Sir, his wounds were healing, sir. So the vitally he was stable, sir.
Why he was given 1 month of brivaracetam and epitoin, both? You didn't discharge him. Okay, coming back to the burn specific, how do you assess the burns wound? Last question from my side. How do you assess the burns wound and classify?
Sir, depending on the depth of the wound, sir.
Yep. So tell me, based on depth of the wound, what are the things?
So, sir, it is first. It is classified into first degree, second degree superficial, and second degree deep, and full thickness. And then full thickness one.
Right. And how do you differentiate three clinically?
We don't, sir. We defer it to the plastic surgeon.
So this might be an exam question. So you classify it based on the color, blister, pain sensation, capillary refill, and accordingly you will have the recovery time. When the superficial are there, they are quite red in color. There won't be any blisters, but they are extremely painful, very, very painful. But you can get a capillary filling. And you get a second degree superficial, you will have a pink to deep pink, and you will have blisters. They call it as a Nikolsky sign, which is in the other dermatological conditions. They are also extremely, extremely, extremely painful. Even if you touch, they will be having pain and sluggish refilling. Once your deep burns are there, you still have got pink to dark pink or red. They will be there. There won't be any blisters. There will be less of the pain sensation. So if the patient present with look like a severe burns and he is not complaining of pain, he is bad. He's got a more of a deep dermal burn. And if you have full thickness burn, it's completely white, no red. Everything is got coagulated. There won't be anything there to have blisters, and there will be absolutely no pain. The patient will happily be sitting and smiling sometimes, but he will have associated things also. So this might be an exam question. Right? I don't know whether a pediatric burn gets asked in this.
No. Adult critical care, so I won't.
Refer to pediatrician.
One more thing, does electrical burn qualify for Parkland's formula? Last one. Do we still resuscitate with for electrical burns or for this kind of a patient? Do we use the Parkland formula if it come direct to you, or would you just not do that?
So the electrical burn can it can be lead to flame burn also, sir.
But is it going to be is the amount of superficial burns that you see? Is it going to be estimating the correct volume of depth and correct this thing, or do you in electrical burns you don't need to follow for Parkland formula? And your opinion on this may not be right. There's no right answer or wrong answer here. But what do you think? You should follow it or no?
Sir, electrical burn can initially, if it is presented, sir, on the initial period, sir, it can be just a tip of the iceberg, sir. So later on, after 24 to 48 hours, sir, if we reassess, sir, might be the surface burn area can be increased, sir. So nevertheless, sir, we should initiate the fluid resuscitation, sir, in electrical burn, sir.
A lot of people will say the surface burns don't actually grossly underestimate the extent of injury, especially when you have 25,000 volt. So your CPKs and your urine outputs are more important, and then your volume requirement is not based on strictly a Parkland formula. But so if you're an intensive care unit, see, Parkland was devised by the Burn Center in Dallas, Texas, to take care of people who are away from a health center. So if you're in a center where you have two bright DM students, you really don't need to rely on any of these things, as long as you know how to do hemodynamic monitoring and how to monitor the risk. So CRT, urine output, and then take it from there is probably what. But anyway, good. I think the case was good. I think we had a pretty decent discussion. There was, as I said, this we could have discussed CRBSI, right IJ, Klebsiella, the usual stuff, but I didn't dwell on it because, that happens in every case in ICU in India, that it will go to that. You could have put him on to renal failure and gotten him into CRRT and things. But I think what we wanted is that most of the people suffer in India in exams because they haven't actually never seen it, and they just read a textbook and they come and present to us. And it's important that you heard from Dr. Joshi and, us, the right way of doing. And since this was an interesting one because this was a burn trauma. So this was not a plain burns, and this was not a simple burns where, Parkland could be used or only burns are used. So this was a mix. So this can be very interesting, and very few people in India actually have the ability to check this. So it's a good case. Thank you for bringing it up. And I think we covered most of it. Dr. Joshi, if you have anything to add, otherwise, there are not many questions in the chat box that I can.
Not many. I think only related to antibiotic. Nothing many. Yes, I see you.
Sorry, your comments, Venkat sir.
No, I think I've been listening to both of you, sir. That's the case presentation and the way both of them participated, and both Suresh sir and Anand, they did a fabulous job of taking through their all parts of the burns. I think this is one of the most extensively discussed case with the all areas covered. A great job, Suresh sir and Anand. I think hats off to both of you. Taking time and being here. Over to you, Sasi.
Thank you, Suresh sir, and thank you, Anand sir, giving your time and valuable knowledge to students across the India. It's midnight in the Australia. Still, Anand sir is fully awake and he grilled the students to the core. Thank you, Dr. Himanshu and Mohit, for bringing a good case for discussion. I think we have covered everything pertaining to the burns. Thank you all. Good night.
Thank you, Suresh sir and Anand, and both of you.
Thank
Thank
you,
you.
sir. Thank you.
Conclude.